Good afternoon. We are really looking forward to our webinar today. Thank you for joining us. I know there's a lot of people coming in, so we'll kind of do our housekeeping stuff. Today, we welcome our guest from Syntara. We are looking forward to a robust discussion on their journey on incorporating the Pritikin ICR cardiac rehab across their system. So my name is Jenny Kennedy. I'm with MedAxiom Care Transformation. I'm joined by my teammate, Denise, also with Care Transformation. And Kathy and Laura, welcome so much. Thanks for taking the time to join us. Both are from Syntara, Martha Jefferson Hospital. Laura Decker is the Director of Patient Services, and Kathy Reese is our manager, or their Manager of Health and Wellness. So thank you, ladies, for joining us today. We're excited to hear your story. These are our disclosures. Housekeeping. So there are two buttons at the bottom of your screen. If you would note, the chat option is where you're going to find a link to the presentation. Please use that. We will post it in there, and feel free to download those slides. We will be utilizing the Q&A option for questions. So we will leave time at the end of this session. So feel free to enter a question and we will answer as many of those as we can live today. But those will be in the Q&A section. So use that as opposed to the chat. All right. Well, welcome you guys. We're really excited. I think learning about Syntara as a health system is going to really set the stage for us. So please tell us about Syntara as an organization, and then what prompted or moved you guys into a direction to explore intensive cardiac rehab.
Thank you. So I'm Laura. We are part of a 12-hospital integrated system. You can see on this map that we have 11 of our locations in Virginia and one of them in North Carolina. And we range from community hospital, rural, urban, suburban, to tertiary hospital, very large programs. We have all different demographics, from aging populations, Medicare to those under 65. We have hospitals that have competition right in the community, while others do not. And what prompted us to consider Pritikin, we were looking for opportunities to standardize our programs across the system. We had developed a cardiopulmonary work group where all of the leaders across the system were working together to optimize their programs. And we're looking for ways to enhance our programs both financially and improve patient experience and outcomes, and considered looking at Pritikin. And once we looked at what their overarching goals were, we saw that the culture of Pritikin and the culture that we have at Syntara were very similar, and opted to explore further.
I would just want to add, one of our hospitals actually had been doing an intensive cardiac rehab alongside a traditional cardiac rehab for a while, basically from the time that Medicare had allowed us to start doing those kinds of programs. And we certainly looked at that, but for us, especially in my hospital in Central Virginia, there were some definite challenges to trying to implement. And when we as a work group would discuss what some options were and starting to learn more about Pritikin, it just seemed like a much better fit for us in our particular area to explore how we could partner and we could develop a more comprehensive standardized education, for example, within an established not only patient outcome success, which very much was able to replicate those of other intensive cardiac rehab programs, but also financial feasibility for us. So that was one of the main reasons we decided to go ahead and explore our Pritikin options with Pritikin. So I think that once we started to do that and we worked through this as a work group, we were established as who was going to do what and what the needs were across our systems. As Laura just said, our hospitals are diverse, and they range from very small programs to much larger programs, and you can see 120 to 400 or more patients a year. And it kind of depends on what's around that facility and the resources. So each of those hospitals had its own intentional needs as well that we needed to consider.
That's really interesting, Kathy and Laura. Thanks for sharing that. I'm wondering too, like whenever you introduce system-wide change, like you've just done at Sentara, one of the common things one does is to start with a pilot site or one or two of them or so. So tell us a little bit about how you went about the process of identifying and launching your first programs. I believe you did 2 pilot sites, is that right?
That's right. We did do pilot sites. Martha Jefferson was one of the pilot sites, and then Sentara Careplex also. I would say first, before we even decided around pilot sites, we had to get the executive leadership on board. So it was, as many of you know, when you go to executive leadership, they really want to see the bottom line and see what the financials look like. So we went through financial analysis to see, to compare our current traditional cardiac rehab program and what it would look like implementing Pritikin. So did that work on paper first, and we did that exercise for the 2 pilot sites that we were proposing. And the reason why we decided on Martha Jefferson and Careplex was probably one, amongst the cardiopulmonary work group, we asked for volunteers, to see who was even interested amongst the team, but also looked at the experience of the leaders, their interest, the barriers to implement Pritikin. Was it going to be a fairly easy implementation, or was it going to was it going to involve construction, or was this even an opportunity to get that construction going in a timely manner to be successful and make it happen, I guess. So
Sure.
Looking at all of those different things, that's where we selected Martha Jefferson and Careplex to be the pilot site.
And I also think, just to add to that, from a clinical perspective, we both had robust programs. We both had a lot of tenure in that cardiopulmonary industry, had seen a lot of changes. We're kind of looking down the line as clinically what's coming up. And being able to stay alive also means you have to be able to be financially viable. And I was more interested in what are the patient outcomes going to be. I know that intensive cardiac rehab has excellent patient outcomes. Medicare would not have approved of this if they didn't evidence that in much research. And it's been replicated many times, and Pritikin has done its own studies. And it took me a minute because I had some probably predisposed understanding that it was going to require something different of our patients, and I wasn't sure I could sell it. But after really learning about Pritikin, talking with the people, beginning those discussions, I really felt that this was a win for our program to be able to be one of the first to step into this whole arena and do something different and really grow us in a different way. I've been doing it for a lot of years and seen a lot of change. I was really excited at that point to be able to explore how we're going to do something different for our patients that we hadn't done before.
Yeah, so really important to be very intentional about how you selected your pilot sites here, obviously. How far apart did you do that? I mean, did you do it at the same time, or did one go first and then the other followed?
We started considering our program in like the spring of 2022. It was actually a year before that we started this whole discussion of executive leadership. But we actually started the beginning, and once we decided we were going to do it, we had some T's to cross and I's to dot, like we needed to get our Medicare enrollment certification. And then we had to get our agreements with Pritikin and contracts and things like that. We actually began our training, it was July of 2022. And by November, the end of November 2022, we were in business. So it took that amount of time, which truly isn't a lot, to do a sea change in the kind of care that you're delivering your patients. I want to say that intensive cardiac rehab, traditional cardiac rehab have a lot of commonalities. So I'll talk about that in a minute. But to really make these operational changes did mean that we had to go down a different path and make all those considerations first. So I felt like that 4 or 5 month investment in us really following and doing it the right way with Pritikin leading us was very helpful to make it successful. CarePlex actually went live the end of January 2023, so just a short time after us.
Mm-hmm. Nice.
And that was only because they had a little bit of construction that needed to get done that just moved that timeline out a little bit further.
Sure.
But it wasn't, anything intentional for one to go first or second. It was just a matter of timing.
Yeah.
I did want to add, in making the decision, and where Kathy was talking about her hesitancy, and at the beginning of trying to consider whether to do Pritikin or not, I think some of that was she had very good patient outcomes already, and if we're already doing a really good job with our patient outcomes, what would be the impedance to change? Is there really improvement that is to be had? And come to find out, yes, there is additional improvement, and we'll talk about that more.
Yeah, well, that's great. So obviously a very thoughtful process. I know that there is what's referred to as a readiness rubric with Pritikin that they help you with. So I wonder if you could talk a little bit about what happened next, how you evaluated the process for implementing Pritikin ICR, and then how you rolled it out across the rest of the system.
Sure. So there were several things to consider. And when we looked at staffing, we needed to determine what additional staffing was going to be needed for setting up Pritikin. Certainly, when you add the education classes, you need to consider what staffing you're going to need for that. You add cooking schools and dietitian resources for one-to-one consults, and then whether you need an operations coordinator to help with some of the administrative work is to be considered also. So we looked at all of those different things to determine what additional staffing we would need to roll this out. We looked at facility setup, and this is something that each division had to look at across the system after we determined to roll out across the system. But we looked at, for our pilot sites, what do we need? Do we have current space to do our education, or do we need to be creative in figuring out how we're going to accomplish that? The cooking school workshops include cooking demos with the opportunity for the patients to actually taste the foods that are prepared, and we need to figure out how to do that, consider safe food handling and such like that. Engagement level, I don't think any of us really had any concerns or challenges with that. I think everybody was very excited for the opportunity. And then the budget, like I said, there was a whole lot of financial analysis before determining that we were ready to do this, and that it would be a positive outcome for us.
Yeah, I think in terms of the readiness piece, the reason we went a little bit before another hospital, we were the first to go, is because we did have a lot of these things in place already. We had a separate education classroom. We did have to make some purchases for like a cooking cart. We had to look at our staffing, and we had to hire a dietitian. We did some staff role shifting to be able to enable our clinical staff to also take on some operations coordination and some Pritikin specific, like database management, things like that. So we had some things to do, but we were pretty much already in place with the space and the staffing. And my staff was immediately engaged once the decision was made, and we explained what it was, and Pritikin explained. They were all in. Everybody was ready for that, and that is a huge important indicator for how successful I think a program is going to be. If your staff doesn't believe it, the patients aren't going to believe it either. So we got into it, running basically.
Yeah, 100%. And you mentioned, boy, there sounds like a lot of little details to take care of, and that can sometimes be intimidating to folks. Did Pritikin kind of give you guidance along the way, just to give you ideas about how to be flexible for each, kind of location's uniqueness and things like that, or how did you manage that?
Yeah, I'm glad you asked that question because I wanted to add, Pritikin was absolutely fantastic every step of the way. They are there to lead you through the deep dive, the training, they're right there on site when you have your go live, and continue to be to this day. We have monthly meetings to look at our progress and how we're doing and look at data, and they're great partners to work with. I can't say enough good things.
And they've done this before. So
Yeah.
they have their own readiness rubric, which helps us to. So you start off basically with an introductory phone call. And then we have what's called a deep dive day, which is set up ahead of time, involves all the different partners that you're going to need in your own facility. You're going to need your medical director on board. You need your staff on board. You need your finance, your registration, your billing, your marketing, might be forgetting, but everybody comes together and has this presentation and introduction and understands what the changes are going to be operationally that will impact their specific disciplines. And then after that, the staff are actually provided with these core videos that they can self-pace themselves to understand what we will be teaching the patients going forward. We'll get in a little bit more detail, I think, about what Pritikin looks like specifically, but the core videos were the staff training. And then we actually had the launch day, where, actually right before the launch day, we do one more sort of follow-up and we do presentations, and we're making sure Pritikin is supporting us every step of the way, giving us feedback, talking with us through questions that we have, being there to help us with what is going to be impacting, down the road. And anything that anybody had, they did have an answer for because they've been here before. And then the launch day, they were also with us. And then the follow-up is not just monthly, but sometimes there's emails back and forth. If I have a question randomly, I can go to, my counterpart in Pritikin and be able to have them pretty much get back to me very quickly with the answer. It could be reimbursement. It could be data that I requested. So the partnership continues. It does not end with launch day.
That's really great. Thank you so much for sharing that detail. I think that support and helping to action plan is really critical. But I wanted to go back just a little bit to what Kathy and Laura, you were saying about the difference. So a lot of us, maybe there's not a reason to change. Maybe we feel like we have a robust cardiac rehab program already, or maybe there's challenges in getting patients to enrolling in that. So talk to me and maybe to help educate some who maybe have a broader knowledge of what ICR is, but really what is the difference compared to traditional cardiac rehab?
Cardiac rehab has been around for a very long time, and Medicare approves coverage, which means those other insurers are also following Medicare. And we've been doing this with certain codes for a long time, where basically they're covering a monitored exercise, which is basically an hour or so of individualized monitored exercise. And then there's a possibility of offering education. Medicare provides 36 sessions. Most insurers cover that much, some less, but that's what you get. How you choose to use those 36 sessions is kind of up to the program. And we mostly use those 3 times a week for 12-week sessions to exercise a patient, because it takes 10 to 12 weeks to gain and sustain those significant improvements that we're looking for with regard to their participation in a cardiac rehab program and their healing and restoration for their heart functions. The same exact diagnoses are covered through Pritikin, so there's no change. The same model is the same. The difference is, instead of just getting 36 sessions, you're actually getting 72 sessions, with a much greater emphasis on developing a very comprehensive lifestyle modification program that we can really dig into the things that patients can do to help themselves, not just exercise, that's certainly important, but also looking at heart healthy eating. And that is where a huge component, we call them pillars of education in Pritikin. Heart healthy eating intones not necessarily vegan or vegetarian eating. It's very doable for most people because it's plant-based. Very similar to Mediterranean. So people have heard those conversations, and we really help coach people to where are you in your journey and how far are you willing to go. And adding fruits and vegetables, for example, is going to improve their anti-inflammatory picture and helping them understand how to do that specifically through recipes provided and taste testings. And then we really look at healthy mindset. That's the third level of education, where we are looking at what stress and distress does, and we look at sleep habits and positivity and communications and things that is so impactful if people can understand how that is impacting their health and what they can do about it. So having patients now not just come in for exercise and get random piecemeal education through the clinician, they're also getting exercise plus education class each time they come in. So it doubles the reimbursement. It doubles the time that the patients are there, which you would think would be a challenge, and I can explain my experience with that in a minute. But they're getting a much more comprehensive and standardized, everybody gets it. It's not going to be just, oh, I had time to talk about this with you. Everybody who participates gets that one of those topics each time they come in. And essentially it's provided through comprehensive workshops, which is really digging into the meat of the matter with the topics that are, and there's many variety of topics. There's enough to cover many more than 36 sessions or 36 visits. We have facilitated video presentations with staff discussion. We have the cooking demos, and we have one-on-one health coaching. So the patient just needs to talk about their diabetes and how that's impacting their heart. There's time for that. Maybe strength training is in addition to the regular exercise and the benefits of that. That could be health coaching. They all get a diet consult. That's going to be all reimbursable. So whereas we were stopping at 36 visits, we still do 36 visits, but we're doubling what we're able to bill and provide to the patient. So again, the diagnoses that qualify the patients are the same. Insurers reimburse for the most part. There are a couple that do not, and anybody who is kind of takes on this endeavor will get a better sense as to who are those outliers that still consider this experimental or just don't have that in their policy. But as we know, most insurers cover Medicare. So the same ICD-10s are going to be appropriate for intensive cardiac rehab as well.
No, that's great. And I think one of the points you were about to hit on, and something that was a common theme in conversations, was concern about patients being compliant with big scary words like Mediterranean and vegan diet. So what is your experience and your team's experience with those significant changes in nutrition that I think we're all a little hesitant to implement because our patients struggle with their dietary habits and the ability to afford that? So expand on that a little bit more, if you don't mind.
No, I'm happy to. I believe that the way that the classes are set up, so patients aren't getting it randomly when the staff have time in between their exercise modalities to give them a little bit. They're getting a whole lot more. So once they come in and they go through an orientation, which is what we do in our program, an introduction, we get them started right away in these classes. And my concern was I could have heard my patients where we live saying, I'm not coming 3 days a week, and I'm requiring them to come 3 days a week, but now I'm asking them to come 2 hours, 3 days a week. And I expected to have a lot more pushback and trepidation. But honestly, I did not experience that. And for the most part, I think it's in the cell. I believe that I had to get behind it. My staff had to be engaged and really say, this is what we know is best for you based on our experience. And give it a try, see if you like it. one thing that has been dramatically different for me, and as Laura said, we had really good outcomes before. They continue to be very good, but we've seen like a 34% drop in our blood pressures pre and post. Most remarkable to me is so many patients come back to me just because of my position and thank me for the opportunity to do what they didn't want to do in the first place. And many of them don't want to leave, but that's not our intention. But it's giving them the tools and the resources that they didn't know they needed. So it's a little bit of understanding, you're going out on a limb trusting us, but come a few times, we can pretty much guarantee we'll help you through this. And getting that individual coaching and the really saturation of education doesn't make it have to happen all at once. So they're able to sort of piecemeal it together, and what didn't make sense in week 2 is going to make sense in week 12. And they continue to build upon that foundation. And our team is really good about assisting with that, especially in the dietary realm. Having a dietitian on staff who not only meets with them, but sees them weekly in classes and gets to know them, that's also a win-win for the patient, because they can feel like they're seen, they feel like their specific needs are understood, and they don't have to be vegan, they don't have to do it all. It is a process, but I think the messaging that they get right up front is really important to say, we believe that this is the best for you, and this is how you do it. And that is how we've been successful.
One thing I'll add that we've noticed with our patients, we have always had great patient experience, and I think that we've just enhanced community. They come for 36 sessions for 1 hour, but now they're good. Now they're with us for 2 hours, and the community that they encounter and experience with other patients and with the staff has really blossomed in having them there for a longer period of time.
The connections are much greater, not only with the staff, but with one another. Mm-hmm. And they're not feeling so much of a silo when they come in. So I think definitely having an intensive cardiac rehab program like Pritikin really helps them engage and really commit to things that they need to do. I wanted to just say one thing real quick. Those insurers that do not cover an intensive cardiac rehab program can still be included in your Pritikin program. The only difference is, instead of getting 36 visits, they would get 18 reimbursable visits. And it's coded the old way with the 93797, 93798 codes, just like those of you in cardiac rehab know. But they would sit in on the Pritikin classes, they would just be the same, but they're going to be limited to just having 18 visits, which I think is a substantial improvement in what they're going to get. Some insurers only cover 18 sessions with traditional cardiac rehab. So you think you can definitely help and know a patient, give them the tools that they need to continue after that as well.
No, that's very helpful. Thanks for calling that out, because I think it sounds like just, we do a lot of education in healthcare, but it's showing and going a step further, right? You can tell me all day, but sometimes I just don't know how or have the motivation. So that next level of engaging helps me to become motivated, and then shows me some of that. And along with what you mentioned about sense of community, and maybe there's a little feeling of accountability there with socializing and building a team of healthcare providers, your staff, obviously, and then your peer group. So that's fascinating. I wanted to take this next question a little bit further. So transitioning to your team, because looking at the time commitment and doubling, obviously, probably you had to get their buy-in, like you mentioned earlier. So how did you get your staff buy-in? And when it came to implementation, what were the biggest implications that stand out for you and lessons learned as you made this transition?
The staff buy-in for us was very easy. I think once somebody has an opportunity to learn about Pritikin and kind of erase those predisposed conceptions of what it would entail and understand that it's a very doable program, and almost why not? Why wouldn't you want to give your patients more comprehensive education? Why wouldn't you want to charge more for it?
And all the work's been done. They've done all the work for you. Yeah. All of the information. The patients get a wonderful book that's got all of the recipes in it. It's got all the education for them to have as a resource when they leave. I mean, it's just very well done.
Yeah. I mean, and the staff actually watching the videos that I mentioned earlier, being able to learn more about it, the message was not different than what we'd been doing anyway. Mm-hmm. So nothing had to be like, oh, I have to switch direction and now say something I don't necessarily get behind. That never happened. It's evidence-based and it's also real life. So it allows people wherever their readiness is to come in and to learn and to go and to move towards that optimal health. So I think the staffing part was very easy. I was probably the hardest one to sell because I wasn't sure we needed to do it or wanted to do it. And I really felt like I needed to learn more about it. So once I explored that and could share that with my team, I think they trusted my judgment, but also they were very open to it. I think Pritikin also felt that my staff was ready to go once we got online with that. So, and they're just a very good team anyway. My advice really would be though to kind of start slow. Make sure you have your ducks in the row. You anticipate challenges that might come down the road. Pritikin will also help with that. We did hire a dietitian. We did some staff shifting. You have to look at your scheduling. Now we came off of COVID where we were basically scheduling every half hour to move people through. We had to completely change our schedule. There is a Medicare rule that you can go one time from an intensive cardiac rehab participation, and maybe that person moves out of state and there is no intensive cardiac rehab, but they want to continue to finish their program. They can move down one time to a traditional cardiac rehab program, but you cannot go the other way. So all the patients that we had who are currently enrolled at the time we made this shift to Pritikin were traditional cardiac rehab, could not go to the classes and could not be a part of it. So we had to be very creative in how we were able to continue what we were doing with our patients and finish the group that was traditional and then add the other. It does require a staff member is available each time you do that education class. So you've got to look at your own scheduling and how that's going to work and how you're going to monitor. And some people do what are called sandwich classes, and some people we do it differently than that. I'm always happy to share our operational model with anybody who wants to know. And there's reasons that we do what we do. But it did grow very quickly. We started with 3 days a week. We quickly grew to 5 days a week. So just being understanding if you have your resources and you have your the plan in place, it makes it much easier to begin that growth because it really will happen. And once the patients hear about it, they talk to one another, the doctors hear about it, we were getting many more referrals.
And you want to look at the timing of it too. It was another reason why we were aiming for a November go live. We wanted to go live over the holidays when maybe patient volumes were a little bit lower.
Yeah,
that's true. I mean, we have a very multidisciplinary staff, so teaching those classes allowed us to sort of, anybody can do anything, but maybe this person is more skilled or has more interest in this. So each of the staff members became engaged in their area of focus too. So it gives them another thing to own. I think, I'm a believer that everybody has a piece of the program, not just the manager. So everybody now has their unique contribution that they're able to do. And then the one-on-one time allows them, apart from those classes, to be able to really invest and get paid for what we didn't before, time with their patient. You can do up to 6 ICR classes in one day, which is, if you did that, you'd have that patient there greater than or equal to, I think it's like 331 minutes. Well, no one's going to want to do that I know of, but that is a Medicare-approved. That is not possible with traditional cardiac rehab, of course.
Yeah, well, you've made a lot of really interesting points here, talking through the program and the ability to roll it out despite the location's variability that you may have. I'm sure that led you to want to monitor the program successes and just what is it that really worked well. And Kathy, I think you just alluded to, I wrote it down here, about a 34% decrease in blood pressure for your patients from the beginning to when they graduated from the program. Would you tell us a little bit more about how you've been able to measure the success of Pritikin ICR? And I know you've been around, you already admitted it yourself, you've been around cardiac rehab a long time. So what is it that maybe you've seen different with the Pritikin ICR program, or Laura, what you've seen from that more administrative viewpoint that's demonstrated it's a successful venture?
From a clinical perspective, like I said in the beginning, had pretty good outcomes before. We have been able to sustain those pretty good outcomes. We are an AACVPR certified program, so we do have standards we shoot for, and our programs are set up. Pritikin is totally about that as well, and so we're still seeing those improvements in functional assessment, in depression scores, and the quality of life scores that we were looking at, in addition to clinical measures like blood pressure. CarePlex had significant weight loss that they were seeing with their patients. So it's kind of, what do you measure? When we do our monthly meetings, business meetings with Pritikin, they share other things that I think are also measures of success. Referral rates for doctors. How many patients are actually attending both exercise and education classes? We've been able to have almost all of our patients, it's like 48% of our out of 50 are attending those education classes, which I thought was going to be the biggest challenge. They're not going to want to stay for 2 hours, but they were, and they do, and they look forward to it, and they want to come, and they bring their family members. That's another thing, is we include a spouse or a friend or somebody. And so then it's the family message, and you're not just teaching one person. So our measure of success clinically has been continuing what we did before, but maybe even beyond that. To me, it's really that patient feedback. We do discharge questionnaires, and we do these reports outside of our department when we have patient comments or feedback, and I'm sending them all the time. And I'm supposed to send negative and positive, but I would say 99% of them are positive. The 1% wouldn't even have anything to do with Pritikin. Might have to do with our facility, for example. So it's very rewarding, and I share this with my staff. So I think that really helps us all feel like we're making that difference that we all want to do in healthcare. I'll let Laura talk about some of the financial stuff, because that obviously was really important measure for us to also see, were we successful in that?
Well, I think now we have the attention of the executive leadership, which is wonderful, because we started out with a negative contribution margin. With traditional cardiac rehab, it's really hard to have a positive contribution margin in that kind of an environment. So being able to work with Pritikin and have ICR, we have had a significant increase in our contribution margin, which certainly, it gives us positive attention from executive leadership. And, they're more interested in wanting to grow the service and things like that. So, and that's, looking at that was also the impetus for us to be able to get approval to move this through the other 10 hospitals and make it a system-wide venture. So we looked at doing a financial analysis on each of the hospitals and getting the executive leadership at each of those divisions involved in the decision making and looking at the impact that it would have for them. And moving on to how we implemented at each of the divisions, because each of them had their own challenges of whether they needed to make space adjustments or staffing adjustments, or how can we help each other figure out how to implement. Because once we made the decision as a system, it wasn't, do you want to? It is, no, we are all going to do this. Yeah. So how are you going to accomplish this? What are we going to do to help each other get there? And we did, and we all achieved our goal of implementation by the end of 2024.
Yeah,
So we're
that's really
pleased with that.
amazing. Yeah, that's really amazing. In fact, if you look at this slide here, it looks like you guys are having a great time. I don't know if this is Halloween or what it is, but it certainly like there's some fun being had. Could you tell me a little bit, because you just mentioned you've implemented across all the sites in a really compressed period of time. Did you run into any challenges with space or staff? You mentioned one of the facilities was undergoing construction. So maybe was there any place in which you had to just get really creative in order to make it happen, or maybe ways in which you were able to facilitate the rollout despite some of the challenges or space or just location limitations that you had?
Yeah, I mean, as you can imagine, there were all kinds of challenges. So as far as staffing, there were some divisions that really struggled trying to find dietitians. So Pritikin has something called Pritikin Live, where they can assist and they can provide that cooking school remotely, or they can provide that one-on-one consult through that Pritikin Live program. So if you need a little bit help, a boost in getting yourself going, they have that kind of resource available to you, which is a great partnership to be able to lean into that. Even if you end up you have a dietitian and then all of a sudden you have a vacancy, you can lean into that option as you need to. Then certain divisions had challenges with space. Several of them didn't have any education space. They had to use a conference room, and I know one location, the conference room was down the hall, around the corner. So it was a little bit of a walk for patients to get to, and they worked and got a volunteer to help them to get patients from the exercise space to the education space and back. So had to get really creative on how we were going to overcome these. Some of them actually worked on construction plans to be able to incorporate this model. So all kinds of different challenges. Another thing that we discovered after Go Live was an opportunity to collaborate with our food services across the system. So we've partnered with the food services in assisting us in acquiring the food for the food prep, and in some cases doing some of the prep for us, so that there's not as much prep work involved for the cooking schools. Because as you can imagine, some of our programs are doing these cooking classes 6, 7, 8 times a day.
Wow.
Yeah. And the patients like to eat, so that is always like the favorite day for most of them. And you're giving them opportunity to taste test something, and then here's the recipe, and you like it, Kristen can modify it if you need it. Just taking into account everybody has their own preferences too. So I think that is always like the most popular class. But the feedback that I get has been not just the dietitian, but everybody. I didn't know that. Thank you for providing that. I have what I call repeat offenders. Unfortunately, the disease that we work with is a chronic and progressive condition, and people, even if everything is laid exactly right, their nature of the disease is they need another stent or have something else. Well, the repeat offenders are those who've already been through Pritikin, completed it successfully, continued, but then have to come back and want to come back. And not just once, but multiple times, and want to go through the whole thing again. So that's not our goal, of course, but it tells me that we were successful in working with that patient, that they can go to a different program and not do Pritikin. There are other opportunities that are maybe more feasible for them, but they're going out of their way to come back and work within an environment that they felt comfortable and like, okay, what do I need to know differently that I didn't catch up last time? So 36 education classes or whatever it ends up to be can be really important. And I don't know if I mentioned the one thing that is also available. Somebody like that might have been to food labeling class and doesn't want to go through that again. Well, there's a series of individual videos that are also provided. And we implemented a 2-desk video station for patients with headphones and iPad that they could actually view these videos independently, within our framework, and then we could have that discussion. So there's so much flexibility with the needs of each program and then each down to each person. I think that's a message that I feel like I've been asked since I've started Pritikin, what makes it different. It's really that they'll work with you with what you got, help you go towards what your optimization of their programs resources are, and then start that process and hold your hand throughout.
That's great. And I love that you guys were able to work as a work group. So I hear one benefit from a system is the collaboration, and then there's still the ability to do it based on what each site needs. And I want to call out, because I think around the kitchen and the cooking, I see the cooking cart in this picture because it's like, oh, I've got to have this big built-in kitchen and all this construction. If you have that, yes, but you actually don't need all that, do you? Do you mind just giving a really brief kind of overview on the cooking cart? I think that's a thing a lot of people have questions about.
Yeah, we purchased that cart actually. That's not our dietitian, that's a different one. But we purchased that cart on a recommendation from Pritikin, but there are other options. There was a couple, they said, look at these. We love that because it has the mirror where you can actually see the food prep going on in a couple of different ways. We also have a kitchen, but we did invest in some other supplies like Instapot and some warmers and things like that. But that device right there is really enough. You don't have to have all the other stuff. The size of the program might make the difference. We tend to have a large program, so we need to have the space to be able to do multiple things. We have a dedicated refrigerator. So we are really fortunate to have an environment that we have those resources. Those who don't are still able to do it. It's just got to be done in a different way, creatively. And those who don't have any of those resources, I would say yet, because the goal would be to be able to have the in-person dietary training, if you can, is the Pritikin Live offers a great virtual representation of what we're doing. And sometimes they're also offering the taste testings with those. So Pritikin Live has been a really nice way to fill a gap that some programs have. So small, large, a lot of resources, not a lot of resources. Once you start, it does grow. I think that the administration understands and sees that and tends to support those changes that might have looked like an obstacle or a challenge, all of a sudden become, hey, we worked through that, now look at it.
That's great. And I think it's just so impressive that you guys were able to expand this to 12 locations in that condensed of a timeline. So talk us through just briefly, and then we're going to get to some questions because I know there's some good ones out there. What is, from a system looking across the board, what are some of those big picture wins that you guys have seen after, looking back at this whole implementation and having all the sites on it for a little while now?
I guess one of the biggest wins is probably the standardization across the service line in providing that experience to the patients. We now have the financial stability with positive contribution margin, which is something that under traditional cardiac rehab, we've not been able to attain. And then the patient engagement and patient satisfaction, as Kathy mentioned, I mean, we had positive patient experience and participation before, but the letters that the team has received and the individual letters of appreciation mentioning every single person's name and what their contribution to them personally was and how impactful the program has been phenomenal and just means so much to us in looking at the success of the program.
I do think that they remember it too. We're finding that more patients, when they get ready to leave, have a good plan in place. We've been able to work with them on that, but they understand this isn't going to be a quick fix to anything. I've given this comprehensive perspective to know now, how do I put it in place? I've already started to do that. So I find that is something a little different because we've had more time to help them understand what that will look like for them individually. I think that financially, it like I said, it's why wouldn't you want to do it? You were able to build twice with some initial investment. So there is some resources that have to be looked at, and you have to be accountable to what that's going to be like. It's all ultimately going to be very sustainable for us to continue this, because our numbers are way better and our volumes are better because doctors are getting better patient feedback. So there's just all across the board, we have seen a strong presence in the Pritikin impact for us. So our intensive cardiac rehab works for us.
Very good. Well, thank you so much. We appreciate this information, and I think we're going to open it up for the last about 10 minutes for Q&A. So if anybody has any questions, feel free to use the Q&A button at the bottom on the right-hand side. So not the chat, but Q&A. So we'll go through just a couple of questions.
Well, Jenny, we've got one question here. Just wondering about how you may have gotten buy-in from physicians. I think there's a little concern here from someone in terms of, was there any pushback from physicians who were very comfortable with traditional cardiac rehab and didn't want to either impose on their patients, or did you have to do anything in particular for buy-in with any of your either cardiologists in your practice or any referring cardiologists outside your system?
Part of our marketing what was to reach out to the physicians, but Pritikin did it in our initial deep dive. We had scheduled meeting with our medical director to explain the program. She was immediately interested. I'd had a lot of other doctors, like outside of cardiologists, who wanted to refer patients and had asked us to do more. We couldn't really accommodate it without developing a much more comprehensive overall program. So now we're able to offer something different. So once marketing was introduced, then we did upsell it. We did give everybody information. They provide some physician-related information, like handouts and packets that doctors can look through to say what the change is, and it shows them what they need to know. What is the evidence? What's the amount of improvement they're going to see between this program? What are their patients going to experience from traditional cardiac rehab? We work in a hospital with I have a medical director, and she works within 11 or 12 other cardiologists. So we did convey to all of them what it was, but I also have a nearby hospital's general hospital that does the surgeries, because we don't do cabbages and things like that. So we were able to market with them as well. And they understand that we do something different than the other program in town. And we get a lot of referrals from them just as well. I think that they're hearing that same message, that patients are doing better, go back to them and say, I appreciated the opportunity to be able to do this greater investment program. So the physician piece was not an issue. I don't even have to go back and reinforce that, because once again, just like my staff, once they were on board, they got it and they liked what they saw. So we've been able to replicate very similar outcomes, which they're privy to as well.
Yeah, and as Kathy said, Pritikin is very helpful in that regard, because they have physician-specific information to share, and they really help you develop who should you be sending it to, how do you communicate with them, what would be your plan. So they're really involved in the whole journey.
That's great. And a nice question that piggybacks that is really around enrollment rates. So did you see a change pre and post Pritikin in enrollment rates?
It had to grow because we were getting off the traditional, and we had to reframe our messaging to say, okay, that person is only coming in for an hour 3 days a week. You're going to have to be here 2 hours 3 days a week, or they knew somebody in the program. So we had a little bit of a transition, and I think anybody who's been doing cardiac rehab in a traditional model is going to have that same, I don't know if it's a challenge, it's just something you have to understand will happen.
Well, and some of it was intentional. I mean, we intentionally started on a Monday, Wednesday, Friday schedule with the intention to grow it, to make sure that we had everything in line to be successful.
No, that's great. I think that's great advice to have that flexibility built in as you're getting started. And anticipating that. It's not just flipping the switch, right?
It's not at all. It's very dicey. I mean, without mincing words, it's hard those first few months. I would say about 3 months from the 3-month period that a new traditional cardiac rehab and you implemented the intensive cardiac rehab model. You've got to take those people all the way through, and they're now looking and saying, "Wait a minute, I want to do that too." But Medicare doesn't allow you. If it's a non-Medicare, perhaps they could, and they could just move right into it. But the coding and the charges are a little bit different. The fees are the same. What Medicare will reimburse is the same, but what you get is going to be double that. So that was just one thing that people need to understand when you're making that shift, is it does require that, and reallocation of how you're going to use your staff and your resources for that. We didn't like have everything written and pounded in stone when we started. We had ideas and we had a perspective that we knew we wanted to move towards. So as changes were happening, we were able to shift. Maybe it was shifting our staffing or shifting the scheduling of what we were doing, or accommodating the message to the patients in a different way so that they understood what they were getting in that benefit.
That's great. And I think 2 more questions before we wrap up. This is really helpful. I think the first question is about dietitians. Is the site required to have an affiliated dietitian for the program?
A dietitian is one of the key parts of Pritikin, and it doesn't have to be a full-time dietitian, and the person who does the cooking demos does not have to be a dietitian either. That can be a chef. That can be a person who's got experience in food resourcing. That's fine. It helps, I think, to have somebody do both, and that's what we chose to do. We didn't start off doing it that way either, though. But having a dietitian, because really important are those diet consults, those ability to be able to meet with the patient and give them some feedback and understanding about their own specific needs. So they go through Pritikin training. Every single person who is face-to-face with a Pritikin patient has gone through and completed the Pritikin training program. So I might hire somebody months after I've already started the program. They're not going to just be able to jump in. They have to go through the Pritikin program, which is the same thing that our staff went through very initially. I do think that having a dietitian is essential. They play that's one of those 3 pillars, is that heart healthy eating. So you have to have the resource to be able to back that up, I think.
But keep in mind, Pritikin does a great job in providing that Pritikin Live option. If you are struggling to find that dietitian and you're working on it, you can utilize the Pritikin Live until you fill that vacancy.
No, that's great information, because I think we can get stuck there. So maybe rediscovering there are options there.
Exactly.
Absolutely. Okay, last question. Do patients have the choice to attend or not attend the education session? So maybe they want to do the exercise, but not the education. How do you handle that?
Well, simply no. We don't, that would really remove the idea of the intensive model for us. So we tell them up front, the expectation is that it is 3 days a week for 2 hours. This is what you're going to get. Now, understanding that sometimes there's a conflicting appointment or they have to run out for a family emergency. We do understand that. They can make that up. They can do 2 sessions the next time of education. Maybe it's a one-on-one health coaching with a facilitated video presentation plus their exercise. Exercise does have to happen each time, but we have patients who refuse once they get started. We're like, okay, then you're not buying into this program. I understand. So we're going to have to limit your participation at probably that 18 session mark. So you're welcome to come, but this is what it's going to entail. And they know that up front. So I get to answer those questions and kind of determine their resistance or their acceptance of that. And a lot of it is a sell, but they're getting what's best for them. So as any clinician will tell you, you have to be able to meet the patient where they are and help them figure out how they're going to make it work. Your doctors behind that really make a big difference. A physician saying, I think this is a really good program and I need you to do it. It's a commitment. It's a short-lived commitment in the long life that we want people to have, but it can make a huge impact on whether they get in that revolving readmission door, which is what we're all trying to help them avoid, and optimize their health and quality of life.
Absolutely. Well, thank you. You shared a lot of very useful information, and we've had great participation. So I want to thank you, Laura and Kathy, and the Pritikin team for helping us get this information out. Would also like to share that we do have more detail in a publication. If you would like to, there's a QR code, or you can go to our website and download this case study for more information. If you have any questions or wanted to ask a question and get to it today, please feel free to email us at academy@medaxiom.com, and we will get back to you as soon as possible. Thank you, Kathy. Thank you, Laura. We appreciate your time and sharing your insights and perspective and experience with us.
Yeah.
You're
Thank
very
you for the
welcome.
opportunity.
Thank you.
Appreciate it.
Thanks, guys.
Thank
You're
you.
great. Yeah.